Listen, thank you so much for the invitation to be here. Today, I think my role here is to set the stage for the rest of the talks and discussion. And so really, rather than kind of talking about clinical trials or some of the research, what I'm going to talk about is the epidemiology of Chiari malformation and a little bit about the natural history with and without treatment. As you know, there isn't much out there about the natural history without treatment because we don't really follow these patients quite as well. But nevertheless, I do have some disclosures, some of which are relevant today, actually. Nothing commercial, but I do have research funding for some of the work in Chiari from NIH, from PCORI, and from some of the key Chiari foundations. As you all know, most of this sort of seminal work was done over 100 years ago. And what's surprising, I think, to us is that a lot of the definitions that Dr. Hans Chiari originally kind of proffered are still in play. And today, really, the main thing we're going to talk about is Chiari type 1 malformation. I'm going to kind of give a little bit of review, which will be very basic for all of you, about other types of Chiari malformations. But of course, Chiari type 1 malformation we think about as caudal displacement of the tonsils into the cervical canal. And as opposed to Chiari 2 malformation, which is, of course, occurs in the setting of myelomeningocele. Certainly, we use some of the same treatments from time to time for Chiari 2 malformation, but very different pathophysiology. And of course, it has some very characteristic radiological findings, which you're all aware of. Large massa intermedia, medullary kinking, really sort of malformation or dysplasia of the tectum, for example. And then Chiari 3 and 4 malformation, Chiari 3 being the most severe form, rare, and it's associated with really either an occipital or combined occipital cervical encephalocele, and in many cases is inconsistent with life. Chiari 4 really just being hypoplasia of the cerebellum. And then I did want to take a second and talk about some of the kind of alternative Chiari designations, and especially because later on when Dr. Brockmeyer speaks, he's going to talk a little bit about complex Chiari, and a lot of those kind of cases that are more complex involve some of this alternative descriptors like Chiari 1.5 malformation. And here, of course, we have tonsillar ectopia in the setting of brainstem herniation. And the thing to keep in mind is these are complex cases, and oftentimes in response to a traditional posterior fossa decompression can be complex or unpredictable. But essentially, this is the obex position being caudal to the foramen magnum in association with tonsillar ectopia. And then, of course, Chiari 0 malformation. This was came out of a small series of patients in 2011. We're all sort of thinking about it now as we see syringomyelia. Oftentimes, it can be idiopathic syringomyelia or syringomyelia of other etiologies, can be billed as Chiari 0 malformation. But of course, Chiari 0 really is a very specific kind of definition, which is syringomyelia with CSF flow restriction, but with no tonsillar ectopia. And in the right patients, this can be an effective treatment to do posterior fossa decompression. In the wrong patient, the danger here, of course, is that that the diagnosis is not appropriate, and we should not be considering surgery. We won't be talking too much about this today, but it's important to recognize that these are diagnostic dilemmas. And then more recently, this notion of Chiari 0.5 malformation. And this was out of the Cornell group. And what they described is ventral or ventrolateral ectopia or positioning of the cerebellar tonsils that cause compression of the lateral medulla and can give cerebellar, but really brainstem and lower cranial nerve troubles. So, and there's some MRIs here to show this sort of ventral lateral positioning here on the right. When we think about Chiari malformation epidemiology and of course natural history, but primarily epidemiology, what we really need to think about is not the radiological standpoint, but the combination or intersection of radiology and symptoms. This group doesn't need me reminding that the symptoms are oftentimes headaches, visual changes, can be lower cranial nerve problems like dysphagia. We do see syncope, and then, of course, nystagmus and all these things you see on this list here that can come up, but don't come up uniformly, and that's what makes it tricky. And we always think about Jerry Oakes and others talking about the classic Chiari headache. And this is something that I think I and many use in our practice to help kind of distinguish symptomatic Chiari from Chiari in the presence of other kind of headache types, tension, sinus, migraine, etc. So that classic Chiari headache really is the occipital or suboccipital headache. It is elicited by some sort of Valsalva, laughing, coughing, sneezing, and that it's fleeting. And fleeting, so what does fleeting mean? Actually, the International Headache Society helped us with this recently. I think it was 2 years ago. They came up with definitions of Chiari type headaches, and they defined a Chiari headache as being less than 5 minutes. And that's very helpful. As you all know, in your practices, people will come in and they'll have headaches for an hour or 2 hours or a day. So to have a designation from an accredited headache society saying that Chiari type headaches tend to be short in duration, indeed less than 5 minutes, is very helpful. It's helpful in counseling patients. So I want to make sure everybody's aware of that. That's a very kind of a recent but important advance in how we think about this disease. And of course, what is radiological or what is the radiological criteria for Chiari? This is not settled, and in fact is probably more controversial than ever. Most of the work that cites this so-called 5 millimeter rule came out of work in the 80s, really at the advent of MR, where they did an ROC analysis looking at the degree of tonsillar ectopia. And you can see it, I have it in the middle here, where if they chose a cut point of, let's just say 3 millimeters of tonsillar ectopia, so 3 millimeters, they diagnosed a sensitivity of 96% and specificity of 99.5%. So really, by all rights, that's a pretty robust measure. Of course, what we ended up sort of generally using as a field is this 5 millimeter rule. And I think the reason for that is that we're trying to find that intersection of symptoms and radiological findings. Nevertheless, the sensitivity of the 5 millimeter rule is 92% sensitive and 100% specific. But this is based on 25 patients, really, really small sample size. And so people, of course, have gone through and looked at tonsillar ectopia and found that even when we have 5 millimeters of tonsillar ectopia, many patients in these groups, and you can see the percentages here across multiple studies, many of these patients are not symptomatic. And you all know this from your practice, that somebody with 5, 7, 8 millimeters of tonsillar ectopia very often is asymptomatic and is just managed conservatively, for example. And of course, there have been many other attempts, many other metrics to improve the discriminatory capability of MRI to discover Chiari malformation in a way that is substantiated and important, and has largely failed. So in this paper, many different 2D metrics were evaluated. In the end, none of them really sort of stood out as being a robust marker of Chiari malformation and symptoms. What about syringomyelia? So estimates somewhere in the range of 5 to 85 per 100,000, classified by the NIH as a rare disease. When we think about it in the setting of Chiari malformation, up to 50% or sometimes even up to 75% of patients with symptomatic Chiari are diagnosed with syringomyelia if you look for it through MR. Even in those patients who are asymptomatic may have syringomyelia, and as you all know, offering or thinking about considering surgery, posterior fossa decompression in the setting of syringomyelia is a controversy and something we may talk about a little bit later. Nevertheless, syringomyelia is associated with neurological deficits, scoliosis in particular, or spinal deformity, and pain. This notion of scoliosis is something I'm happy to talk about a little bit later as well. Syringomyelia, when we have patients come into our practices with a syrinx, the first thing we need to do is try to understand why it's there, of course. If they come in the setting of Chiari malformation, perhaps it's obvious, but it can be more complicated. Is there a complex craniovertebral junction issue like basilar invagination? That would certainly impact your operative plan. But also, if the Chiari is mild or insignificant and someone is considering this diagnosis of Chiari 0, we need to look for inflammation, infection, tumors, and other associated CNS diseases. So a lot in there, but nevertheless, of course, syringomyelia is an important consideration in Chiari malformation. And so we come back to this. Does imaging prevalence equal disease prevalence? Because most of the studies that we're going to talk about here over the next few minutes are imaging based. Does imaging prevalence equal disease prevalence? The one thing, of course, to study epidemiology, it would be the ideal situation to study all the individuals of the population. This is, of course, not feasible. Could you select a sample and extrapolate? I think that could be done. That has not really been done. So what do we do to estimate the epidemiological parameters of prevalence and incidence, focusing on prevalence here? Well, we can look at surgical series, but of course that's quite biased. Most of the data that we have is around retrospectively available images. There are a number of studies that have looked at healthy volunteers. These are weighted towards adults, so are also biased. And then there are national healthcare systems which give robust data in insurance and payer databases, which are, of course, limited as well. So all these have shortcomings. But the best, probably one of the best cited papers in this came out of the University of Michigan about 15 years ago. This was thousands of patients who underwent brain or cervical spine MR imaging at the University of Michigan. About 3.6% were identified with Chiari malformation. Of that 3.6%, which was 500 plus, 23% had a syrinx, and most of the syringes were in the cervical spine. The location of syrinx relative to in the setting of Chiari is something that has been studied and is not quite as settled as this finding may suggest. Syrinx prevalence was higher in girls, and of those patients with Chiari, about a third of them tended to be symptomatic and went on to get surgery. So this is the article I think is probably most cited. But when we look at all the data, including much of the excellent work looking at national databases, I think the best way to think about it is a range, and these are really broad ranges. So if you look at images alone, so just neuroimaging, the estimates of the prevalence of Chiari is somewhere around 0.24 to 3.6%, with that last paper I just showed you being the highest. And of those, somewhere between 1/3 to 2/3 of those patients are symptomatic. If instead of looking at image-based estimates, you look at symptomatic Chiari, then the numbers are quite a bit lower. And you can see even in the range of 7 to 20 per 100,000, so much, much less. Looking at that same study of syringomyelia from Streley et al. From the University of Michigan, the prevalence of syringomyelia was somewhere in the range of 0.83%. But again, if you look at symptomatic syringomyelia in this sort of seminal study from Northern Italy, it's much lower in the range of about 5 per 100,000. It's important to recognize, of course, that the prevalence of Chiari is likely to be affected by age and ethnicity and other factors like race and socioeconomic status. The prevalence of syringomyelia related to these factors is less well studied, but certainly is related to age. Today, we're going to hear about treatment-related outcomes from the other speakers. Something that I've thought and studied a bit. Today, we're going to hear about treatment-related outcomes. But in the absence of treatment, what does natural history look like? The best data suggests that it's mostly benign. So if, for example, you did not have any symptoms at presentation, the risk of needing to go on to get surgery is actually quite low. Patients will always ask you, of course, listen, I have this Chiari malformation. What are the chances it's going to get better over time by itself? And it's been studied a little bit, mainly through MRIs, and there's about a 50% chance that it'll remain stable over time, at least for the period of time you'll follow them. In some cases, it can improve. The tonsils can so-called reduce or ascend over a period of 10 to 12 years. And in some cases, of course, it can get worse. If you do see increasing tonsillar ectopia, you should at least be considering whether there's another cause at play. And that could be just in a very small child, the development, but in adolescents and young adults, we need to be thinking about a secondary pathology. And again, in a study of about 200 plus patients, only 4 developed new symptoms and 1 developed a syrinx. And there is a variability of data here. So about 3% of patients end up in these latter 2 studies towards the bottom of the slide here, going on to need surgery if initially offered conservative management. It is, of course, important to recognize that there are a lot of modifying factors, especially in pediatric neurosurgery. Many of the Chiaris we encounter are associated with other neurological conditions. This list is exhaustive, so we won't go through it, but many of these, NF1, other phacomatoses, connective tissue disorders, and then, of course, craniosynostosis and hydrocephalus and other things. So this list. I won't go through it, but it's important to recognize how we think about natural history and treatment is very much related to these comorbidities, especially in certain circumstances. And, of course, all Chiaris are not the same, right? This is something that I think that we could be faulted of thinking for many years, although not recently, that that maybe we should be thinking and treating Chiari in a similar fashion. But of course, this example is a 10-year-old male, daily episodes of sharp, fleeting occipital headaches, went on to have a posterior fossa decompression with duroplasty, and did well. This one is just a different kind of case. This is a younger child, occipital headaches, was diagnosed with a family and personal history of hypermobility. So this patient was managed conservatively, but you can see, these modifying factors matter. This is a 14-year-old with spinal deformity in what turns out to be quite a large syrinx. And of course, this was managed with posterior fossa decompression with duroplasty. And actually, in this particular patient, the spinal deformity corrected, which of course is an area which we can talk about later. And lastly, this is a patient with syndrome, a syndromic patient with Pfeiffer syndrome, lots of complexity around craniosynostosis, hydrocephalus, ventral brainstem dysfunction, and ended up getting a posterior fossa decompression, but also occipital cervical fusion and ventral decompression. So, there are all sorts of modifying factors. These are the ones that can be seen, especially in older adolescents and young adults, but CSF leak, venous hypertension, that obviously could be seen from in the youngest of children from the stenosis of the jugular foramen. So lots of modifying factors that should be considered in how we think about the natural history. I'm just going to make a plug in my last minute here that we need to be doing a better job thinking about outcomes. For the most part, many of our studies rely heavily on a Gestalt physician-based outcome. I'm glad to see that we're integrating more standard techniques like the Chicago Chiari outcome score into our studies. I also would like to advocate for patient-reported outcomes in our studies, not just physician-assigned outcomes like the CCOS. Here's one example. This was developed by Dr. Shannon when she was at Vanderbilt, but this is a health-related quality of life instrument, which involves 45 questions across the domains of pain frequency, pain severity, and non-pain symptoms, and then psychosocial influences. So I'll stop there and just say thank you for the invitation to participate today. It's been really great, and I do want to apologize for the technical issues. I have to say, it sounds like an excuse. I've not had that happen before, especially not on the international stage. So I'm somewhat humiliated, but thank you.
Thank you very much, Dr. Limbrick, for that excellent lecture on the complexities of Chiari and complexities of understanding the epidemiology and the natural history, and also giving us a summary of the what we know about the epidemiology and natural history. Can I please bring Professor Klein, Olivier Klein, and Dr. Elias to ask you their comments on your lecture and their questions before we go to the other faculty and to the participants. Professor Klein, thank you, sir.
Yes, thank you very much, and thank you very much, Naren, for your kind invitation and for organizing this session. I first of all want to thank Dr. Limbrick for this lecture. It's a very comprehensive lecture, and I only have a few questions or comments. Chiari type 1 malformation is a rare malformation, or supposed to be a rare malformation. Here in Nancy, I'm responsible of one of the 6 French center of reference for Chiari malformation, and I see 4 to 5 new cases a week, and so did my colleagues. So it's supposed to be a rare malformations, but most of the time now it's an incidental finding. My question is, do you perform polysomnography when you investigate a Chiari 1 malformation? Because we have, when we find more than 6 sleep apnea of central origin, we proceed to surgery, whether the child is symptomatic or not. What is your opinion about that?
Great question. And I would say that if you can obtain that on every patient, I think it's very helpful. I have to tell you that in my practice, I ask about it, about sleep disordered breathing. And if there's any suspicion, I will follow up with a sleep study. I'm not sure it's feasible for me to get it on every single patient. And as you know, there is good evidence that sleep disordered breathing does respond to surgery. And so I do think there's a great rationale to do it. I think that one thing that I didn't mention just in the interest of time is some of the work that our group and other groups are doing suggests that that Chiari malformation is a brain-wide disease, not just a cerebellar tonsil, at least in some groups. So we see all sorts of symptoms that may or may not be related to the cerebellar tonsils. And the reason that's relevant is it may or may not respond to posterior fossa decompression. Nevertheless, I think sleep disordered breathing is one of those that does. So I think it's a great idea, and would love to see more from you and about this. It's certainly an area of interest, and people have written about it. So thank you.
Thank you. Thank you very much. I have a second comment. Just you mentioned it. We have to check for craniocervical junction abnormalities, and if present, we must sometimes do a fixation at the same time of the decompression.
Thank you for that question. I'll just give you a little insight into my practice. Not that you asked, but I'm going to do it anyway. I do think that I think assessing for that in every patient in some way makes sense, whether it's doing flexion extension X-rays or looking on the MRI scan for seating of the OC joints, C1, C2 joints. I think it's really important and probably an under-recognized problem. So I really appreciate your comment. One of the things that I have done in the past is help to coordinate the Park-Reeves consortium, and what we did study the incidence of requiring our patients who underwent OC fusion in our data set, and it was somewhere around 2.5% of those patients ended up needing it. A little bit lower than I know some people will anticipate. So I would say that my general practice is to start with a posterior fossa decompression, and if it requires OC fusion or some stabilization down the road, then I'll consider that. But generally, it's not my first go-to just because of that Park-Reeves data. I hope that's helpful.
Okay, thank you very much. Just a last word, if I can, Naren.
Sure, of course.
In one of your slides, it is written that it's a disease. So do you think it's really a disease or just a malformation in numerous cases?
Yeah, I guess I don't really know the answer to that. I referenced this, but one of the things we've been doing is testing genetics on about almost 2,000 patients now. And I would say it is that's a tough question. It's a malformation in many cases, but in other cases, I think it is the result of other pathology. And I know that many of you on this Zoom are aware of that and understand, as you've said, the notion of craniocervical instability as being etiologic, or the other things that come to mind are cerebrospinal fluid hydrodynamics, connective tissues, venous sinus outflow. I mean, there are many different etiologies. I think one that I think is that I think about is brain overgrowth. You might say, what is that? Well, brain overgrowth, a good example of that might be NF1, where there's an increased head circumference, and the actual tissue inside the skull has outgrown the skull. So in that case, it may be more of a malformation or mismatch. So I guess that's a long-winded way of saying I think it depends.
Right. So
Yeah.
thank you very much again.
Thank you.
Thank you.
Thank you, Professor Klein. Dr. Elias, can I please invite you to comment?
Thank you, Naren, for this wonderful your symposium, and thank you, Dr. Limbrick and Klein. Those were wonderful comments and a nice overview. One question I had was related to collagen diseases. We're seeing a surge of Chiari-related concerns with patients with PDS. Not sure what your experience is in that arena and how to address that. The other comment I had from the sleep apnea, Brendan Rock in Alabama recently put out a nice paper in JNS Beats showing, as everybody's here is starting to notice, that those cranial nerve dysfunctions and sleep apneas are quite prevalent in that patient population. But you also have to compare it to the other Chiari malformation that has a similar pathology, Chiari type 2, and those sleep apneas are present in that population, and we don't do the decompressions on that patient population on a regular basis due to mortality and morbidity. So I'm not sure what your thoughts are in regards to that question. Should it be a factor in our decision making with sleep apnea, or is it more in their cohort they had more obese patients that had those dysfunctions, or more severe Chiari malformations that needed the decompression? So interested in your thoughts on these two topics.
Yeah, thank you. I really appreciate those two comments. The sleep disorder breathing, I'll start with that just by saying it's complicated. I don't think, oftentimes we don't do surgery on Chiari-2 malformation because we worry that much of the pathology is related to the development of the brainstem, or is sort of not necessarily reversible. And I, even in my time in practice, I've seen the field sort of bias towards the treatment of hydrocephalus and supratentorial things rather than decompression. That has changed. Interestingly, I feel like in my new job here, I see more transitional patients, and I see lots of problems associated with prior decompression, which are really challenging to treat. I would say that sleep disordered breathing, at least my understanding of the data is that decompression can help. I think that more to come on that. And other things we're seeing: dysarthria, dysphagia, and then even speech, like childhood apraxia of speech may be related to Chiari malformation. It's unclear if decompression will help in those things. So I think more to come. The craniovertebral instability, I see that Professor Goel is here as well, is I think an area where we really need to focus. In my mind, the two things that we're not good at studying right now, whether it's in big groups or small groups, really two of them: pain, the connection to pain, and the connection to connective tissue disorder. So this has got to be a focus of what we do going forward. I would say that I look for connective tissue disorders in every patient now. I do the Beighton scoring myself in every single patient. It's tough to get these patients to get evaluated in genetics or rheumatology or these other specialties where you might want to rely on their diagnosis. So I do it in every patient, and I do FlexX in most patients. And then the last thing, and I will tell you, this is the influence of Professor Goel on my own practice. I look at the OC and especially C1, C2 joints on every single patient. I scroll parasagially to look for that before I'll talk about doing any surgery. I'm sure he'll have a comment about that. My own my own practice is to rely more on posterior fossa decompression rather than fusion procedures, but I'm certainly open to that and try to do my best to investigate that in most patients.
Thank you.
That's great. Thank you, Dr. Limbrick. Dr. Limbrick, there are a couple of interesting questions on the chat box. If you have time, I would be grateful if you could reply. For the reasons of time, I'll need to now move to Dr. Barbaraji. Thank you very much, excellent, for the excellent lecture and for the fielding the great questions and leaving us with things to think about. Thank you.